and I am pleased to introduce our speakers for today's presentation, Dr. Hannah Mitchell and Dr. Estelle Morin. Dr. Hannah Mitchell is a researcher and an infectious disease pediatrician at BC Children's Hospital, as well as a clinical assistant professor in the pediatric infectious diseases at the UBC Faculty of Medicine. She has special interests in translating research findings into day-to-day clinical practice and preventing infections in immunocompromised children. Dr. Estelle Morin is also a researcher and infectious disease pediatrician at BC Children's Hospital. Her interests include infections in immunocompromised transplant populations, immunizations, and antimicrobial stewardship. Both Doctors Mitchell and Morin work closely with the BC Children's Hospital's multi-organ transplant program and the Family Immunization Clinic to optimize the care of pediatric transplant patients across BC. Today, they will be presenting and answering your questions on measles in children with organ transplants. Welcome, Doctors Mitchell and Morin. I will now hand it over to you.
Thank you for that really kind introduction, Paulina. I don't know if I've met everybody on the call, probably not everybody, but I'm Dr. Estelle Morin. As Paulina said, I'm one of the ID docs at BC Children's. And so I'll get started on the first part of the presentations, and we'll take a little bit of a break halfway through, and Dr. Mitchell will continue with the second half. So today we're hoping to answer some of the following questions for you and other families of children with solid organ transplants. So what do we need to know about measles and specifically in children with transplants? How can we keep children with transplants safe from measles infection? And can children with transplant receive measles vaccines? And so I just wanted to start by asking the question, why are we talking about measles today? And so there are a couple of reasons for that. The first is that we're seeing more and more measles infections in North America. Traditionally, we would worry more about measles exposure when people were traveling to areas abroad where there was more measles transmission and less vaccination. But there have been rapidly increasing numbers of cases of measles seen within North America, including various parts of Canada. To date, most of the cases have been in Ontario and Alberta, and there have been 12 cases in BC, most of which have been travel related. And so this is just a map here just showing that the two provinces with the majority of the cases. And this is from over 10 days ago, and there have been more cases since. So the second reason why we wanted to talk about measles today is there are some updates to recommendations about the measles, mumps, and rubella vaccine in children with solid organ transplants. So we'll focus on that for the second half of the talk. So what is measles? Measles is a very contagious viral infection. It's spread through the air when an infected person breathes, coughs, or sneezes. The virus can actually survive in small droplets in the air for up to 2 hours. So even if someone has left the room, the particles still linger there. People can become infected with measles when they breathe in these droplets or they touch objects that are contaminated with the virus. What are the symptoms of measles infection? And so following an exposure to someone who has measles infection or to a space where there has been someone who recently had measles infection, there is usually a gap of around 7 to 14 days before someone develops symptoms of measles infection. This time can be as short as 5 days or as long as 3 weeks after an exposure. Fever is usually the first symptom of a measles infection, along with conjunctivitis, which is red, watery eyes that may be sensitive to light as well. Other symptoms include cough, runny nose, and if you look closely, you might notice some white spots inside the mouth in children with measles infection. Following these symptoms, a rash develops about 3 to 7 days after, and it starts at the hairline, spreads down to the face and upper neck, and then moves down to the rest of the body. And the rash lasts around 5 to 6 days. So this is just a picture here of how the rash might look in different skin tones, and also shows the red eyes, the watery eyes, runny nose, and fever as well. So does measles present differently in children with solid organ transplant? So things to note about children with solid organ transplant or children whose immune systems in general don't function as well, they might present a little bit less typically. So their measles rash might not look the same, it may not be inextensive, or it might be more extensive, or they may even present sometimes without a rash altogether. The other thing to note is that children with transplants have higher risk of measles complications, and that might include lung infection or pneumonia, and rarely can also include inflammation or infection around the brain, which is otherwise known as encephalitis. So is your child protected against measles? So in terms of our routine vaccine schedule, children receive measles-containing vaccines at 12 months or 1 year of life. That's usually a combined measles, mumps, rubella vaccine. And they'll get a second dose of measles-containing vaccine at about 4 to 6 years of age. And that one also comes paired with varicella, which is chickenpox. MMR and MMRV vaccines are both live attenuated vaccines, which means they contain a weakened version of the measles and other viruses that are within that are described in the name of the vaccine. Now, in children who are planned for transplant, vaccines can be given earlier than these timeframes, but some children may only receive one dose or may not have ever been vaccinated for measles. And this may depend on the timing of their transplant or the age of the child at transplant, or if there are other medications or conditions that affect the immune system that might make it so that they can't receive the vaccine before transplant. If your child has been vaccinated for measles, we're actually able to check if they have antibodies against measles. And the test that we do is called measles IgG. So you may see these on requisitions or lab recs in the future. So if your child does have antibodies at a certain level to measles, then they would be considered protected against measles infection, or we might call them immune is the other term that we'll use. Some children may have received measles-containing vaccine before transplant, but unfortunately might have lost that protection over time. And so we can't just assume that vaccines that are given before the transplant might last after the transplant as protection from the vaccines. We can't assume that it might last after the transplant as well. So there was actually a measles antibody or IgG lab requisition emailed to our MOT families through the MOT team in March. But if you don't have this or you are haven't heard back about results, please feel free to reach out to the MOT team, and we can always add it to your routine labs or communicate the results to you as well. When this test is done, the turnaround time is about 2 to 3 days. So moving on to what you should do if you hear that your child has been exposed to someone with measles infections. And so you might hear this from someone you know, or public health might call and let you know if you or your child have been in a space that has been where there has been someone who has a measles infection. And so if your child is exposed to measles and we know that they don't have antibodies against measles, there's actually an immunoglobulin or antibody product that can be given to children to reduce their risk of becoming infected with measles. This product is given through an IV, which takes several hours, so might require a bit of a stay in a hospital or emerge. Or the other option in children who are younger, they might be able to get a faster shot directly into the muscle, and so that doesn't take as long to administer or to give. This antibody product helps to prevent infection in about 75% of people. So it's not bulletproof, but it is it protects a majority of people who receive it. We do ask that if at any point you are worried about a measles exposure, or if you're worried that your child might have a measles infection, regardless of whether your child has antibodies, please let the MOT team know before presenting to care so we can involve the right people like public health, our infectious diseases team, and make sure that we're directing you to the right place so that you're not going to a center that doesn't have, for example, the antibody product that you might need. So the next question is there a treatment for measles? And so while we have a lot of treatments for a lot of infections, unfortunately, there are no antiviral medications to treat measles infection. The care of children with measles infection mainly involves managing symptoms. So for example, giving medications to help reduce fever, or it involves treatment or support for complications of measles infections. So that might include giving someone IV fluids for dehydration, giving them oxygen if there's lung involvement, or some children with measles might also have a bacterial infection like ear infections or lung infections, and they might need antibiotics for that. And so that's I think my portion talking about measles background and prevention and treatment. And so maybe I'll pause here and see if anyone has any questions about what we've talked about so far. And we can also set up the second half of the talk too.
Thank you so much, Dr. Morin. Does anyone have any questions at this point? I think you can put up your hand or pop it into the Q&A. Okay, wait, do I see someone? Oh, someone's just entering the room now. Does anyone currently have any questions? I've got a couple that I wrote down. So I will ask a couple questions, and then if anyone does have any questions in the meantime, you can either put it in the Q&A or raise your hand, and then we can help get your question answered. My first question is, do you need the measles IgG test if your child never was able to receive a vaccine before transplant? Like, do you just assuming they just have zero protection, or should they still go get the test just in case?
So, and Dr. Mitchell, please weigh in as well. I don't if there's never been measles vaccine, and unlikely given the current the previous rates of measles in the community, you don't know that there's been measles infection. You don't need to get the measles IgG test, because very likely is that most likely is that it won't be positive because there's never been vaccine or infection.
Okay. Thank you.
Yeah.
Anyone else have any other questions? I have one more question. Writing down my questions. So for the immunoglobulin treatment, can you clarify the time, the window as to when it needs to be administered post possible exposure?
Yeah, absolutely. And I'm sorry that didn't actually include that in the presentation. But when we're giving that that antibody or that immunoglobulin product, it's within 6 days of an exposure. So the earlier you can give us a call at the MOT team, the earlier we can arrange for that to be given within that window. Because once we go outside the 6 days, the effectiveness of that antibiotic product is no longer there.
Perhaps the other way around, what would usually happen in BC is that you would get a call from public health, for example, say we identified someone with measles on a flight that you recently returned to. So you could have been exposed. And what that means is kind of from the time you were exposed to the time you found out you were exposed, there are probably going to be a couple of days in between. So that means you actually need to get that IV immune globulin quite quickly to be within that 6-day window, kind of before the virus replicates enough to cause infection, regardless of whether you received it or not. And of course, the other way around, if you think you know or you think you've been exposed, let us know, because we would then talk to public health, because that's important information for them. And if there was a question about possible exposure, they might already have more information about the possible source, and they might be able to tell us, oh, this is true, or they might be able to say, we investigated, it actually was not a true exposure, it was a false alarm, so to speak.
Okay, thank you. Thank you for clarifying. Do we have any other questions before we move on? And you will have an opportunity to ask questions again at the end, so no worries if you don't have anything right now. All right, Dr. Mitchell, are you guys ready with your second part?
Which one's yours?
Oh, I just have to open it. Yeah, I'll just need one moment to switch screens here. Oops.
Okay. Mm-hmm. And just a reminder, again, we are recording the session today, and we'll be sharing it with other families who were not able to attend.
This one.
Okay, I think it's the other one.
There we go.
Yeah.
Are you seeing the full one or the?
Yep, see the full screen.
You see the full screen? Okay. Hi, everyone, Dr. Hannah Mitchell. So like Dr. Morin said, we have vaccine against measles, and it's part of measles, mumps, rubella vaccine. So it means that you actually get vaccinated against we're talking about measles today, but you actually get vaccinated against all 3 viruses. We don't have a single measles vaccine in Canada. You do get a weakened virus as part of the vaccine. As Dr. Morin said, it's usually given at 12 months and 4 to 6 years of age, and especially if your child has had transplant young, and that's a lot of children with heart and liver transplant, there is a chance that they never received the vaccine, or that they received a dose early, kind of before the 12 months of age. And of course, if you've never received the vaccine, you're not going to be immune. If you received the vaccine, but you were very young, so younger than 12 months of age, there is a higher chance that that immunity is no longer there. And after transplant, you were probably told to avoid live vaccines. So far, kind of traditionally, up until now, this MMR vaccine has not been given after transplant, but this is now changing as we have more information. So can children with organ transplant receive MMR vaccine? Because it's a live weakened vaccine, we previously did not recommend it for people with weakened immune systems, such as organ transplant. And I should say that that was not necessary, that was not because we had evidence to show that it's not safe. We just did not have enough information to prove that it is safe and that it works. And we now have more experience from other hospitals in Canada and around the world. I should say that this experience mainly comes in children with liver transplant. So all the studies that have been published so far have largely involved children with liver transplant and a very small number of children with kidney transplant and essentially no children with heart transplant. Which is not to say that we cannot give it to children with other types of transplant, but we do not have as much information as we do in liver transplant. So what we can tell you so far, based on the studies that we have, is that MMR vaccine is safe and effective in children with liver transplant, with kind of stable immune status based on their immune suppression and based on additional tests. And you're probably wondering whether we've been giving the vaccine to children in our MOT clinic at BCCH Children's Hospital. So the vaccine is not currently part of the provincial vaccination program for children with transplant, meaning that you cannot get it at public health. We just finishing developing a guideline on how to give it in our family immunization clinic. So I'm happy to let you know that we will start giving it to children with liver transplant as of next week. And that will be with physician approval and sign off. So you need to receive an approval from your transplant physician. So that's Dr. Gutman in our case, and transplant infectious disease physicians first. And we, of course, hope to expand the program to children with kidney and heart transplant as well. And I should also say that live attenuated varicella vaccine, which is similar to the MMR vaccine in the sense that it's a live weakened virus, has been available to children with transplant since 2021, and kind of based on very positive experience at BC Children's. It's actually now part of a provincial program. So as long as you've been assessed and your transplant team says it's okay, you can actually get it at your primary healthcare provider or at the public health unit. And we really hope to kind of build on the success of this program to expand the program and provide the MMR vaccine first to our family immunization clinic and then hopefully across the province. So you've done the blood test or your child has never received the vaccine. You know that your child is not immune to measles. So what's next? How do you know whether they can get the vaccine or not? So as of this month, if your child has had liver transplant and that happened at least a year ago, they're otherwise healthy and they haven't had any recent rejection. They have been on stable immune suppression for the last 6 months, meaning that their levels have been within the target range, so not too low, not too high, and that the transplant physician and pharmacist are not planning to making any changes to their immune suppression in the coming months. Then we will give you blood test requisition to do some additional tests to make sure that that they have a normal functioning immune system aside from being on immune suppressive medication. And after all that, someone from the transplant infection diseases team will review the vaccine with your primary transplant physician and the pharmacist, talk to you about the side effects of the vaccine and when is the right time to get it, and will then sign off the forms and you'll be able to go to the family immunization clinic and get the vaccine at the time that's convenient for you. And again, we're doing this in a staged approach. So right now we're starting with children with liver transplant because most of the information about safety and effectiveness comes from children with liver transplant in other countries. But the plan is to eventually make that available to children with kidney and heart transplant as well. And part of the reason why the vaccine has been given mainly to children with liver transplant is because they're usually just on one immune suppressive medication rather than two. And they're usually not on mycophenolate, so usually not on MMF or MPA, which kind of causes additional immune suppression and also makes it somewhat less likely that you will respond to vaccine, so that you will develop immunity after the vaccine. All of you probably wonder what are some of the side effects of the vaccine. So kind of in the studies after transplant that we have so far, the side effects were generally mild, so the vaccine was well tolerated. Now, expected side effects within the days of vaccination that are common, kind of pain, swelling, redness at the injection site, kind of short-lived fever and malaise. And this is all common. Like really the only thing I tell to people is, don't get the vaccine if you're planning on playing if you have a big sports game coming up the next day. And of some other side effects that are more specific to MMR vaccines that happen about kind of 5 to 30 days after vaccination and are related to the kind of this live weakened virus replicating in your body are a rash that looks like measles, but it's milder. And that kind of happens in 1 out of 10 people with transplant. More rarely, you can get kind of swelling of the glands in the cheeks and around the neck, sort of almost like a mild version of mumps. And that's rare, but we have seen it in children with transplant who received the vaccine. And then kind of related to rubella component, you can get joint pains, which is a bit more common in teenagers than younger children. And again, it's rare, but can happen. And again, it's transient, it goes away. So far, kind of in hundreds of children who have received the vaccine, we have not heard of any children actually developing measles, mumps, or rubella kind of proven infection outside of these kind of transient symptoms. We will, so for anyone who gets the vaccine at our MOT clinic, one of us will call you to ask about side effects. And that's for two reasons. One is to obviously, we would like to know if you've had side effects, but like as importantly, we would also like to hear from you if you did not have side effects, because I think that's important information to gather and information to share going forward as more people are able to get the vaccine. And with all that being said, of course, concerned about anything that is or could be a side effect, please don't wait to receive a phone call. Please call the transplant team or on-call team after hours, and they'll get in touch with someone from infectious diseases. So far is generally safe and well tolerated. There are some side effects that can happen related to vaccines specifically. Someone from the transplant team will be able to provide information and guidance if you're at all concerned. The other question that comes up is, can vaccines, and in this case specifically MMR vaccine, cause organ rejection? As kind of families of children with organ transplant, you know that organ rejection is rare, but it can happen for a number of reasons. And so kind of what we know about live vaccines and rejection comes from other hospitals and from studies where MMR vaccine has been given. And of course, because the vaccine has been given to hundreds of children and rejection is fortunately a very rare event in general, I can only share with you based on what we know. But from a small number of children with liver transplant who did develop rejection kind of in that 1 year after a vaccine, kind of the physicians and the study teams reviewed those rejection episodes. And in all those episodes, they kind of determined that the rejection was most likely not related to the vaccine. In other words, they found an alternative explanation for why the rejection happened. So it could have been, for example, due to the level of immune suppressants not being within the right range. And then the last question people commonly ask is, well, I'm coming in to get my MMR vaccine. Can I get any other shots at the same time? So I kind of divided that answer into two parts. So for children who are not immune to varicella as well, we would actually give you the chickenpox vaccine first. So that's the other live vaccine. And then give the MMR vaccine 12 weeks later. And that's for two reasons. So unlike in children who did not have organ transplant, we cannot give chickenpox and MMR at the same time. Even though we are very concerned about measles right now, kind of chickenpox is actually still more common. So everything being equally, your chance of getting chickenpox is higher than the chance of getting measles. And finally, with chickenpox vaccine, should you develop infection from the chickenpox vaccine, we have the antiviral. We don't have the antiviral for the MMR vaccine. So we would give you chickenpox first to make sure that that went well for your child, and then follow that with MMR vaccines 12 weeks after your last chickenpox dose. So that's for live vaccines. For any non-live vaccines, so that's kind of your seasonal non-live flu shot, pneumonia, hepatitis, and so forth, that can be given at the same time as measles or other live vaccines if you prefer. If you prefer to do it separately, that's completely okay as well. So these are all the slides that I had about the measles vaccine. Before we go on to more questions, I just wanted to give a quick update about a non-live vaccine that will be recommended and available for transplant recipients this summer. So it's actually a pneumococcal vaccine that protects from pneumococcus bacteria that can cause pneumonia, ear infections, but can occasionally also cause more complicated infections, such as infecting the blood, spreading to organs, and occasionally causing meningitis, which is a brain infection. So as of right now, children with transplant would have received the pneumococcal conjugate 13 vaccine that protects from 13 strains. And in addition to that, receive the PPV, that's the polysaccharide vaccine that protects from 23 strains, but is unfortunately not very effective, and the protection only lasts for a couple of years. So as of this summer, this will be replaced by the PCV20 vaccine. So if your child has already received PCV13, and did or did not receive PPV23, we would recommend that they get a shot of PCV20. For very young children who are still completing their PCV13 series, we would switch, and again, they would complete with PCV20. So it's currently not publicly funded, but this should change at some point this summer, and we will be sending out a letter to let you know about it. And it's recommended for everyone with transplant, regardless of the previous pneumococcal vaccines you've received. As you would have guessed from the number, instead of protecting from 13 strains, it will actually provide from 20 strains, which is essentially most of the strains capable of causing serious infections. And related to that, obviously children with organ transplant are a small group. We're always trying to learn more about vaccines in children with transplant. So if you live close to BC Children's Hospital and you either have a child with organ transplant or sibling who is healthy between the age 5 to 16 years, the Vaccine Evaluation Center is currently looking for people who are willing to provide blood specimens, and that can be done kind of along with your usually done along with your routine labs. So if it would be a vaccine and then two additional visits. And I know everyone is busy and it's sometimes difficult to find any time to participate in the studies, but if you think you might be interested, please contact the transplant team or the Vaccine Evaluation Center. And there's a small stipend that comes for each visit to at least reimburse you for some of your trouble. But so back to measles now. I'll stop sharing, and I'd be very happy to answer any questions now, or if you think about them afterwards.
Thank you, Dr. Mitchell. I'm opening the floor for questions from any of our attendees. You can either put them in the Q&A, or you can raise your hand, and we're happy to answer your questions. Or not me, but one of our infectious disease specialists here. While we're waiting to see if anyone has any questions, I'm curious to know how effective the MMR vaccine has been in the transplant recipients who have received a dose or two.
Mm-hmm. Yeah, thank you for that question. So in transplant recipients, and again, that's mainly children with liver transplant, the vaccine has been about 90% effective. At least in the first year. So we know that, say, if we vaccinated 10 children with liver transplant in our clinic, about 9 out of 10 would develop protection. So majority, but not everyone. And what we also know is that this protection lasts, but it does decline over time. So there is a possibility that you got a vaccine after transplant, but that you might need to get another dose in the future. And I suspect that this number of how many children respond to the vaccine is going to be somewhat lower once we start giving it in kidney and heart transplant. And that's mainly because children with heart or kidney transplant are usually on MMF. And we just know in general that's not specific to MMR vaccine that that MMF kind of interferes with your ability to respond to vaccine. And that does not mean you should stop taking MMF when you get the vaccine. Please don't do that. I just want to kind of give you a realistic answer on what to expect. So a good chance that you will get protection, but it's not 100. Like with most things in life, it's not 100%.
Thank you for that. I think also, can you share for families who are traveling this summer, whether airplane, driving, or going to different places where maybe the exposure level is more risky if people are traveling to Alberta or Ontario, for example. And obviously, even if your child is eligible for an MMR, a vaccine is going to take a little while before they can actually get in the queue, so to speak. So what kind of advice do you have for families who are concerned, like masking? Is that something that will actually work? Washing hands, the things that we've heard during the pandemic. What measures can people take?
For sure. And maybe I'll speak to the vaccine part, and then maybe Dr. Morin can speak to the second part. So with the vaccination, after you gotten the vaccine, with any vaccine, it takes about at least 2 weeks for the vaccine to be effective. And we would usually give you a blood test requisition about 4 weeks after the vaccination to check if you've developed protection. So, if your child has got liver transplant and you're planning on traveling in August and are hoping to get the vaccine now, please contact us now, because we need a little bit of time to get everything organized. We can certainly arrange all the tests and talk to you within a couple of days, but it still takes a while from the time you ask about it to get vaccinated to actually develop immunity. And of course, for other people who are not immune but traveling, which is exciting, right? Like, you get transplant so you can go on adventures and go outside. There are probably a couple of things that you can do if you're not immune, and kind of trying to minimize your chance of being exposed, or at least knowing what to do if you're exposed. I'm not sure if you want to start.
And so the challenging thing with the spread of measles is that because it lingers for a little bit of a while after someone's even been in the space, and because it's spread through these small droplets that float in the air, some of our methods of masking and hand hygiene and hand washing might not be as good as if it was something that was only through contact with a surface, but those can help reduce risk of other infections as well if you're traveling to areas with respiratory viruses and things like that as well. Being kind of vigilant with if you're in very crowded places, especially in areas where there are higher rates of measles. For example, when we say traveling in Ontario and traveling in Alberta, it's not necessarily the whole province that has those higher rates, but it might be in certain areas. So knowing a little bit where those areas are. For example, in Alberta, most of the cases are kind of south of Calgary or in the southern area of Alberta. So depending on where you're traveling, some of those risks may not be as high as in other parts of the province. And then Dr. Mitchell, did you have?
Well, I think often the first thing I would say, if you if your child has been vaccinated and if you haven't checked the immunity yet, now would be a good time to do it. Because if your child has been vaccinated and you're immune, that's really important information to have. And if they're otherwise healthy and unstable immune suppression and they've been exposed, they would actually be treated no differently than a child without transplant, right? You would still contact our team. We would tell you you're immune. You don't have to do anything. So kind of knowing your status. And then if you're traveling, and that probably goes for anything, not just measles, but kind of knowing, making sure you have a phone numbers of people to call, and kind of knowing where the hospital or the pediatric center is, so that if you're told that you've been exposed, what is the closest hospital? Where can you get immune globulins within that 6-day window? So if you're going somewhere remote, can you actually get somewhere within a day or two where you can receive the immune globulin if you need to. So kind of, it's hopefully very unlikely that you will be exposed, but if you are exposed to measles, chickenpox, something else, kind of just thinking about that plan ahead of time rather than kind of in a moment of, some panic if you received a phone call saying that there's been an exposure. And again, like we are obviously here in BC, but we kind of as infectious disease team and physicians have capacity to work with other parts of like teams in other parts of Canada and overseas. So if you're at all concerned, give us a call and we'll do our best to find all the information we can, regardless of kind of where you may be. We obviously have colleagues across the world who are happy to help.
Thank you so much. Just one last chance for questions from the group. And also, you are free to email the team later for questions. If you think of something later on, then feel free. I know both Dr. Mitchell and Dr. Morin are very open to working with you and dealing with your specific questions. So with that, I'm going to close this webinar. Thank you so much to Dr. Morin and Dr. Mitchell for joining. Thanks, Paulina, for the introduction. And thank you to the families for joining us for this webinar. And the recording will be sent out to the rest of the transplant families. So thank you, everyone.